Hospital Medicine as we kick off our Fight the Resistance campaign. I'm Ebola Wallaby, a Senior Project Manager with the Center for Hospital Innovation and Improvement at SHM, and I will be moderating today's webinar. I'd like to go through a few housekeeping items before we begin today's webcast. Currently, all phone lines are muted, and in order to be able to speak during this webinar, please make sure to enter your PIN number as you are prompted when you first log in. A prompt should have asked you when you logged in, or it will pop up on your screen as a reminder later. Today's webinar will be recorded and will be accessible again through SHM's Fight the Resistance website. There will be a Q&A session at the end of today's presentation, and in order to ask questions, please raise your hand by clicking the icon within the toolbox you see on your screen, or typing your question in the available question box space. If you raise your hand, I will call on you by unmuting you, and you'll be able to ask your question. If you type in a question in the space, I will read it out loud for our presenters. Also, please note SHM staff will be live tweeting today's webinar, so please be sure to participate in the live discussion if you can with the handle @SHMLive. Today's presentation will be highlighting the importance of hospitalist involvement in antimicrobial stewardship. And at this point, I would like to pass the presentation to Dr. Larry Wellickson, SHM CEO. Larry?
Yes, good afternoon, everyone. This is Larry Wellickson calling in from California. As Mobola said, I'm the Chief Executive Officer of the Society. And I wanted to thank everybody for taking the time out of their schedule and logging in. SHM is committed to being one of the leaders and active participants in this fighting the resistance campaign. And I wanted to urge everyone on this call to look for ways to commit at your local hospital to get this stewardship program moving forward. And I think our audience is young enough and savvy enough with social media to understand how powerful it can be if you begin to share this information from the campaign with your colleagues. What we're trying to do is get to a tipping point where this moves from being an idea to being implementable changes that will obviously improve things for our patients. So with that short welcome, I wanted to turn things back to Mobola, who will introduce the faculty for this call.
Thank you, Larry. So today's webinar will be presented by Dr. Scott Flanders and Dr. Melhem-Bou Alwan. Dr. Flanders is currently a professor in the Division of General Medicine at the University of Michigan, where he serves as Associate Division Chief of General Medicine for Inpatient Programs and Associate Chair for Quality and Innovation for the Department of Internal Medicine. He is the Director of the University of Michigan's Hospitalist Program, which has grown to include over 100 faculty members and staff. Dr. Flanders was a founding member of the Board of Directors of the Society of Hospital Medicine and is a past president of SHM. He was editor of the Society's publication, The Hospitalist, from 1997 through 2003, and was the deputy editor for the Journal of Hospital Medicine from 2005 to 2008. In 2013, Dr. Flanders was awarded the designation of Master in Hospital Medicine by the Society of Hospital Medicine. Dr. Bou Alwan is an internal medicine trained hospitalist at West Georgia Health in LaGrange, Georgia. Dr. Bou Alwan completed his training in internal medicine at Emory University in Atlanta, Georgia. He currently serves as the chair of the Antimicrobial Stewardship Subcommittee as part of the Hospital Quality and Patient Safety Committee of the Society of Hospital Medicine. He also chairs the Antimicrobial Stewardship Program at West Georgia Health and has implemented a multidisciplinary team approach to rationalize the use of antimicrobials there. At this point, I will turn over the presentation to Dr. Scott Flanders. Scott, please begin whenever you are ready.
Great. Thank you very much, Mobola, and I appreciate the opportunity to be here and speak to all of you on behalf of SHM's Fight the Resistance campaign. I'm going to start first by citing a little bit of the background for some of this work by talking about the human toll of antibiotic resistance. And this first slide shows the cover of a publication put out by the CDC in 2013 titled Antibiotic Resistant Threats in the United States. And this report listed antimicrobial resistance as one of the single most important threats that face our population. And while certainly people recognize the problems with treating patients coming in with a primary infection with an antibiotic-resistant bacteria, what many don't recognize is as our bacteria develop resistance to our antibiotics, we lose the ability to treat people who are at increased risk for infections because of an existing illness. Cancer is a great example. Treating patients with chemotherapy predisposes them to infections, and if we can't treat those infections, we can't treat the cancer. That's an important concept to understand. The box on the right of the slide highlights the CDC's attempt to quantify the magnitude of the impact that these infections have on our patients. The CDC estimates that at least 2 million illnesses annually are caused by infections due to bacteria that are resistant to one or more antibiotics. It is estimated this leads to over 23,000 deaths annually related to infections with antibiotic-resistant bacteria, and there are many more patients who die of conditions that are complicated by the development of antibiotic-resistant infections. So there's a major human toll related to resistance. Next slide. And the only problem we are trying to tackle, it's not just antibiotic resistance. This slide shows another big problem we're seeing in U.S. hospitals. This data comes from HCUP, which is the Healthcare Cost and Utilization Project, sponsored by AHRQ, that shows discharge diagnoses of Clostridium difficile, or C. diff, infections in U.S. hospitals over a decade period. And what the slide shows is that we've seen over a 400% increase in this infection. The CDC in a recent study estimated that this infection causes up to 15,000 deaths annually and contributes to well in excess of $1 billion of excess healthcare costs. Next slide. And the big driver that we are here talking about today that is contributing to our increase in antibiotic resistance and C. difficile infections is, of course, antibiotic use. And I specifically use the word use, not necessarily misuse. Use is an overarching category that includes a lot of very appropriate use of antibiotics, but also misuse, which is our target for intervention. Next slide. So to elaborate a little bit more on the problem, I'll focus on the bullet points on this slide. It's important to recognize that a very large percentage, over half, up to 60% of hospitalized patients receive antibiotics over the course of their care in our hospitals. And obviously, a lot of this antibiotic use is necessary and critically important. We are seeing patients with increased comorbid conditions, receiving immunosuppressive treatment for organ transplantation, chemotherapy, and a variety of other treatments for very important conditions our patients are struggling with. And antibiotics are critical for treating the infections that these patients develop. The problem, however, is highlighted with this next bullet, that when evaluated somewhat rigorously, it's been estimated that between 30 and 50% of the antibiotic use that we see in hospitalized patients is potentially inappropriate. And this is what we need to work on improving. Next slide. It also may help to try and identify some of the opportunities or areas where we are seeing inappropriate treatment. And that was done in this study here, which provides a nice example of improvement opportunities. This was a study that was done at a university hospital over just a 2-week period. And what these authors found, and I highlighted in the last slide, was up to a third of antimicrobial therapy was deemed unnecessary when they looked at the medical records of these patients. These authors importantly lumped that inappropriate treatment into some key buckets that are highlighted on the slide. Furthest to the left in the blue bar was excess duration of therapy. Our hospital-based providers are treating patients with infections longer than is necessary. The next big category was non-infectious or non-bacterial syndromes. This is a tough one. It is often difficult for physicians and providers to distinguish between bacterial and non-bacterial processes when a patient is initially hospitalized. So this is a challenging one to tackle, but an important contributor to antibiotic overuse. And finally, in the last bar, treatment of colonization or contamination that never needed antibiotics in the first place. The authors of this study also recognized that a lot of patients received overly broad spectrum antibiotic therapy when more narrow spectrum treatment would have been appropriate and would have treated the infection. And this study is not unique. There have been many others that have shown very similar similar findings, a lot of improvement opportunity. Next slide. It's also important to ask, as you think about improvement work and tackling this problem, what are the types of infections that are driving antibiotic use in U.S. hospitals? What are the key conditions? And this slide shows data that came from the CDC, published in JAMA 2014. And I'll tell you, we have done similar work here at the University of Michigan and have found identical results, which is that the top 3 conditions that generate antibiotics in our hospitals are: number 1, urinary tract infection; number 2, respiratory tract infections, and pneumonia in particular; and number 3, skin and soft tissue infections. And it's in that rank order. In fact, if you combine UTI and pneumonia, those conditions alone count for over half of all inpatient antibiotic use. So these are the conditions we need to target with our improvement efforts. Next slide. As we think about our improvement work, we have to ask the question of who we are going to do this work with and who we are going to engage in our improvement work. And clearly, many hospitals are fortunate to have robust stewardship teams, antibiotic stewardship teams leading this work, often an infectious disease physician in partnership with a pharmacist who may or may not be trained in infectious diseases specifically. That is a luxury. Many hospitals do not have those robust stewardship teams. And I would argue, even for ones that do, engaging frontline providers and doing this work is critically important. So why engage hospitalists in particular? First off, there are a lot of us. Over 40,000 hospitalists in the United States is estimated based on American Hospital Association surveys, caring for patients in over 70% of U.S. hospitals. And in fact, if you look at our nation's largest hospitals, over 200 beds, over 90% of those hospitals have well-established hospital medicine programs. And looking at it from the patient perspective, there have been some studies that estimate that hospitals care for up to 50% of Medicare patients, non-surgical patients. And so that leads me to the next bullet. If I highlight that we're caring for a large percentage of hospitalized patients, they receive a lot of antibiotics, and a lot of that antibiotic use is inappropriate, I think we have to recognize that hospitals may be part of the problem. And we absolutely, therefore, must be engaged and be part of the solution. The third bullet is an important one. I think hospitals feel as much, if not more so than any hospital-based providers, the problems that we see with antibiotic resistance and complications such as C. diff. These are our patients that we are struggling to treat with antibiotic-resistant infections or seeing suffer with infections like C. diff. And so presenting this as an opportunity to improve the lives of our patients, prevent these serious adverse consequences, I think really hits home with hospitalists. And finally, hospitalists are very comfortable with the QI work that's needed to do this type of improvement work related to antibiotic use. It often takes system redesign, sometimes advanced QI methodology, and hospitalists are a great group to partner with in doing this type of work. Next slide. So where should hospitals think about starting if you want to begin to tackle improving antibiotic use and developing a stewardship program? The CDC put out a very nice publication where they highlighted the core elements of a robust stewardship program, and they're shown here on this slide. First bullet here is leadership commitment. Having leadership of your hospital or health system behind this work is important to support it. The second thing relates to accountability and responsibility. Having a single leader who is identifiable for leading this improvement work and delivering on outcomes is important. Pharmacy leadership is important. Antibiotic use tracking, reporting on use, and reporting on resistance gets to the issue of data. Improvement work is very hard to do without reliable data that tells you where the problems are and what your progress is. The second to last bullet here, educating providers, is critical, but I would say the last bullet here is where the rubber meets the road. We need to act, and it speaks to implementing specific improvement interventions in your hospitals. And I want to say a few more words about that. Next slide. I don't have time to do justice to the myriad interventions that are possible to improve antibiotic use in U.S. hospitals, but I want to focus on a few that have developed from work that we have done in partnership with the CDC, the Institute for Healthcare Improvement, and the Society of Hospital Medicine that has specifically tried to test and evaluate lots of different potential improvement opportunities in hospital medicine programs across the country. And after a lot of work, This slide shows 3 examples of interventions that hospitalist groups felt were effective and also feasible to integrate into their practice. The first relates to documentation. It seems obvious, but it's a critical, important step. Our patients are often handed off to multiple different providers. Consultants are seeing the patient, and having a place that's visible where we can see what antibiotic the patient is receiving, what the indication is, which day of therapy it is, and what the anticipated duration of therapy is critical for best practices with antibiotic use. The second bullet relates to identifying appropriate treatment duration. And treatment duration should be based on local adaptation from guidelines that target the 3 big conditions: UTI, pneumonia, and skin and soft tissue infections. What we found in our work is many institutions had guidelines, but when you looked at treatment recommendations and duration of treatment, you'd see ranges, and sometimes they were broad. You would see 7 to 21 days as treatment duration recommendations. And obviously, sometimes providers get it wrong and think more is better for patients and tend to err on the side of overtreatment and inappropriate durations. So establishing appropriate and shorter durations when safe and effective is critical. And the last bullet speaks to implementation of a 48 to 72-hour antibiotic timeout. Stopping 2 to 3 days after a patient has started antibiotics for a potential infection to ask, was it an infection? If not, doing this facilitates appropriate discontinuation of the antibiotic. If it is an infection, do we have culture data, or do we have opportunity now to narrow our spectrum of treatment to use less broad spectrum treatment, and this timeout facilitates that type of de-escalation. And all 3 of these were felt to be valuable, important, and leading to improved antibiotic use. Next slide. So summing things up from my perspective with respect to hospitals and stewardship, I clearly believe that stewardship is in the hospital's wheelhouse. Some programs may be led by stewardship programs, others may not, but hospitalists, I think, are a critical partner in doing this work and will be comfortable doing this work. I think it's critical to engage hospitalists because interventions to improve use have to be integrated into the daily workflow of hospitals and other providers. If this is just viewed as another add-on, another task on top of all the different improvement work that's needed to be done, that's going to be a barrier to getting it implemented. And working with hospitals will facilitate that integration. And finally, as I have alluded to before, hospitals are very comfortable working in multidisciplinary teams. In an ideal situation, that may include a partnership with an infectious disease physician, pharmacy leads that lead robust stewardship programs. If not, the hospitals may have a bigger role in this work. But I think they're critical partner in designing and implementing interventions. And I would say doing this work is critical for our patients, and they deserve no less than a concerted effort to improve the way we use antibiotics in our hospitals. So with that, I'll turn the presentation back over to Mabola.
Thank you, Dr. Flanders. At this time, I will pass the presentation to Dr. Bual Wan, who will be discussing the Society of Hospital Medicine's Fight the Resistance campaign. Dr. Alwan?
Yes, thanks, Mabola, and thanks everyone for joining us at this kickoff webinar for SHM's Fight the Resistance campaign. And next slide, please. So this campaign by SHM aims at educating hospitalists on appropriate prescribing habits and use of antimicrobials, as there's growing data to suggest that antimicrobial stewardship programs or antimicrobial stewardship efforts in general improve quality of care for our patients through the optimization of treatments of infectious conditions and the reduction of adverse events from antibiotics. There's also strong evidence for improved patient safety through improved patient cure rates, reduced failures, and a significant reduction in C. diff infections and antimicrobial resistance. And like most quality efforts from your experience, most quality efforts come with a significant cost reduction for the healthcare system. And by being here today, you fulfill part of the first aim of this campaign, which is to improve awareness among hospitalists on this crucial issue. It is also important to note that as hospitalists, we are not the only people involved in this. This is not an individual effort. Antimicrobial stewardship is a team approach, and I will detail more about who are the appropriate members of the team to be included in my upcoming slide. The second aim for this campaign is to induce behavior change through offering educational resources on the treatment of the most commonly encountered infections in the hospital setting. And those were mentioned previously: UTIs, pneumonias, and skin and soft tissue infections. And these recommendations and educational resources are based on the latest evidence and society guidelines. And we're hoping that with these individual behavior changes would eventually translate into culture changes at your institutions with long-lasting implications. The third aim of our campaign is to provide these resources not only on the use of antibiotics, but also on practical steps to build and optimize the use of antimicrobial stewardship programs if they're already in place at your institution. We know that the day-to-day functioning of hospitalists makes it very difficult for everyone to recreate all these resources on top of everything else that we have to do. So by providing these resources and making them handy for everyone to access them easily, we're hoping to make this process much easier for everyone. Next slide, please. Fighting the resistance on a day-to-day basis cannot be achieved without each and every one of us consistently doing at least the following three things. So the first part is to, again, recognize that this is a team effort, and we should be working with a multidisciplinary team on antimicrobial stewardship. Leadership buy-in is an extremely important factor and may even provide avenues for compensated work for this on this topic for hospitalists. As soon as the hospital leadership or hospital administration realize the impact or the benefits of having such programs, our case becomes much stronger as hospitalists working on this topic. And we also need to partner with ID specialists whenever available. I come from a community program where we do not have infectious diseases, so by default, hospitalists and pharmacists are kind of in the forefront of leading these campaign efforts. Since a huge chunk of antibiotics is prescribed in an intensive care unit, maybe involving pulmonologists or intensivists may be a good idea for similar teams. Clinical pharmacists are integral as they have the experience required with antibiotics, and leaders for these antimicrobial stewardship programs have been either hospital medicine physicians, infectious disease physicians, or pharmacists. So any of these people can take on the roles of leading this team because, as was noted earlier, leadership is one of the integral qualities that will hopefully induce success in these programs. In addition to the physician involvement, hospital epidemiology, infectious control, and microbiology lab personnel are also very important. Nurses are the ones who are administering these antibiotics, and involving them as well may be a good place to highlight whether antibiotics are necessary or not, or to bring this question up to the physicians at some point. IT in this day and age, with computerized order entry and electronic medical records, which are almost universal, are also invaluable when it comes to incorporating these antimicrobial stewardship efforts into the daily orders or order sets and electronic reminders that we get to make it part of our daily flow, not an extra task. The second thing that we have to do on a day-to-day basis is every time we pick up a patient, and that happens a lot, we should ask ourselves whether the patients that are on antibiotics are receiving antibiotics for the appropriate indication, and whatever those antibiotics are, whether they are appropriately treating our patients, taking into account our hospital-specific characteristics, including resistance patterns, for example. And this may be a chance for working with other team members to come up with protocols to address empiric choices for suspected infections, taking into account local resistance patterns. And the third factor, or the third thing that we should be doing, again, on a daily basis, is to rethink our antibiotic treatment time course. And this has been mentioned before, but it's very important to drill down this concept. A lot of patients come in on antibiotics as they are admitted in a critical condition or deteriorate while they're in the hospital. And antibiotics are usually some of the first medications to be added when someone's not doing too well. So it's important to have an antibiotic timeout at 48 to 72 hours to reevaluate whether the patients still require antibiotics or whether their presentation was caused by a non-infectious condition and antibiotics may not be necessary at all at that point. We should also be mindful of the appropriate treatment time course for infectious conditions, and this is one of the one set of resources that we're providing with this campaign. appropriate treatment time courses for infectious conditions. And it's also necessary to set up treatment time course and preferably set a stop date, not necessarily day 3 or 14, maybe setting up a stop date will alert everyone to that particular date. Another important consideration is the route of administration or the delivery method of the antibiotics. If a patient is able to take PO and a PO alternative to their current IV medication is available, then it may be a good idea to think about potentially transitioning patients to PO if they're doing better clinically. Again, another important element in rethinking the time course is whether there's new clinical data that's out, including cultures that could assist us in streamlining or de-escalating the antibiotic choices to specifically treat the patient conditions, but not necessarily overtreat or overuse the big guns, which we are constantly running out of. Next slide, please. And although these interventions you may think may take some time to implement, and this may be true, gathering a team and working on particular topics, there are things that we can do today. And I'm quoting Eric Howell's Antibiotic Stewardship and Hospitalists, The Bedside is the Frontline article here, to say that there's a bunch of things that we can do after we leave this webinar today. The first one is to partner not just with healthcare providers, but partner with our patients, because a lot of patients come in expecting antibiotics or requesting antibiotics for potentially non-infectious conditions, and taking the time to partner with the patients and educate them about the appropriate use of antibiotics and the potential harms associated with use and misuse of antibiotics may be a good place to start. The second thing that we can do, again, today is to make sure that every time we prescribe an antibiotic, it is prescribed with the particular condition in mind, as that condition is something that we're going to be tracking, especially in the era of persistent handovers between hospitalists. We need to know exactly why the patient's getting the antibiotic to see if the need for this antibiotic has resolved. And third, work very closely with infectious disease colleagues whenever available. I wish we had infectious disease doctors at our hospital, because that would have made our lives so much easier. But the reality of things is that in some community hospitals, this luxury is not available, and we have to do some of the things on our own, partner with pharmacists and other healthcare team members. But if you have infectious disease specialists, work very closely with them, as they have the experience that is necessary to induce change on this topic. Next slide, please. And at this point, I'd like to refer you to the website for this campaign, fighttheresistance.org. You can download these posters and use them in your local institutions, and Mobola will be discussing some more aspects of this campaign. Mobola?
Great, thank you, Malham. So yes, as Malham mentioned, we do have the fighttheresistance.org website, which is up, where physicians are welcome to go to the website and download the posters to hang up in their facilities. SHM is also conducting a Twitter campaign that will start next week, where you and your staff can win an SHM hoodie and coffee for your team by fighting the resistance. In order to join, we just ask that you tweet a photo to at SHM Live, hanging the Fight the Resistance poster up in your hospital using the hashtag #FightTheResistance. We encourage the photos to be unique and convey the enthusiasm, high visibility, and teamwork required to support the culture change. So some of the rules for the contest are that it begins November 16th and ends December 23rd. The posters will be distributed in the November 2015 issue of the Hospitalist, and they're available for download, as I mentioned, on the fighttheresistance.org website. SHM staff and the Antimicrobial Stewardship Subcommittee will review submissions based on creativity, enthusiasm, high visibility, and teamwork. Winners will be notified via Twitter direct message about claiming their prizes. As I mentioned previously, the prize packages will consist of an SHM hooded sweatshirt and a $15 Starbucks gift card. Additional rules and details about the contest can be found at fighttheresistance.org. At this time, we're going to open the door up for questions. And so if your hand is raised or if you've written out a question in the chat box, I will go ahead and read it. One of the first questions that we have in the chat box is, from Dr. Joy Matsuyama, and she's asking if hospitalists are not routinely writing antibiotic indication, day, and duration of therapy in their current notes, what's the best way to get them to start doing this routinely? Also, would you be able to share your treatment duration guidelines for the top 3 conditions you mentioned and how they may be tailored to different sites? So I will leave this to Malham and Dr. Flanders as well.
I'd be glad to start with that. So I think the first question relates to facilitating documentation. So I can give you some examples of what some of our hospitals did to facilitate this. So some hospitals created a template that they used for writing their notes. Many institutions have these, many hospitals programs have this in this era of electronic medical records, and all it took was them to add a data element on that template that facilitated writing down the indication, day of therapy, and anticipated duration of therapy. Another example was a hospital that used their multidisciplinary rounds to drive this work. So as they were rounding as a team, which would include the pharmacist, a nurse, hospitalist, care manager, and others responsible and contributing to the patient's care, they would move from bed to bed, and on their checklist of things they looked for, in addition to a lot of the other things we think about with quality improvement work, whether it's urinary catheters, VTE prophylaxis, they had a particular section that asked if the patient was on antibiotics and was it documented, what was the indication, day of therapy, and anticipated duration of therapy to facilitate that documentation. Most of the hospitals that successfully did this audited it. They looked at points in time and would give feedback to their group when they were not routinely documenting those key aspects. So that was a key driver. I believe the last query, and maybe Mabola could facilitate this, we'd be glad. I would be glad to share University of Michigan's algorithm and guideline for our common conditions that emphasize appropriate treatment durations. And maybe Mabola, you could facilitate that communication offline from this call.
Absolutely. Thank you very much. The next question we have is from Dr. Arjun Srinivasan. I'm going to unmute you. Please feel free to ask your question.
Hey, Mabola, it's Arjun. I want to thank you so much. Can you hear me okay?
Yes, we can hear you. Thank you.
Great, fantastic. Well, I just wanted to really applaud SHM for taking such a leadership role in this. I'm Arjun Srinivasan, and I'm the Associate Director for Healthcare-Associated Infection Prevention Programs at the CDC. I've done a lot of work on efforts here at the CDC to improve hospital-based antibiotic use, antibiotic stewardship. I've had the privilege to do a lot of work with Scott on this topic. And more a request than a formal question. I'm always eager to hear from the hospitalist community to know if there are things that we at CDC could be doing or could be doing more of to help you in your efforts. We are certainly closely partnered with SHM as part of the Fight the Resistance campaign and hope this is an open dialogue, but did want to come on the line to really applaud the work that you guys are doing and let all of you on this call know that the line is always open for any of you here at CDC. If you have specific ideas for things that we can do, please be in touch with the SHM leadership or directly with me. We are happy to help in any way that we can. And that's really all I wanted to say.
Thank you so much, Arjun. Appreciate it. The next question I'll be reading is from Linda Diertring. Any suggestions on how to curtail prescribing patterns of overzealous infectious disease physicians?
Well, I should ask Arjun to get back on the line and answer that particular question. It's interesting. I've actually heard that comment from others that while certainly infectious disease providers are important partners with this work, sometimes there can be particular providers that have strong opinions that more may be better, and certainly there are some patients for whom that's true, but I think not universally so. I think my personal opinion is that's the type of situation where an open dialogue about what you're trying to accomplish, going to certain data and national guidelines, and in particular, those guidelines that have been adapted by many studies and institutions to target more appropriate use, and having a dialogue as to why we are not practicing in a way that's been shown to be effective, yet reducing antimicrobial overuse. I think data and an open dialogue is probably the best strategy for dealing with that particular situation.
Thank you. The next question is from Jennifer Barnett. I'm going to unmute you, and you can feel free to request your question, please. Jennifer? Jennifer Barnett, did you have a question? Okay, maybe not. Okay, the next question is please provide examples of pharmacy-led interventions to assist hospitalists with antibiotic choice and duration.
I can give a local example of a pharmacist-based intervention. So it relates to the 72-hour timeout. So we here at our hospital, we're trying to figure out how to operationalize a 72-hour timeout within our hospital medicine program. And we have the luxury of having pharmacists that we do work with on a regular basis that help us manage things like our anticoagulant drugs, help adjust dosing based on renal function and a variety of other conditions. So what we basically did was added into our usual interactions with our pharmacists a 3-day-a-week, Monday, Wednesday, and Friday, session when we were already talking with the pharmacists about drug utilization in our population. And to that, we added all of our hospitalists would run their list of patients with the pharmacist and ask the question, is the patient on antibiotics? Do they have an infection? If not, can we stop the antibiotic? If the patient does have an infection, do we have culture data that allows for tailoring of that treatment, adjustment of the dose if they need it based on kidney function or other issues, and developing anticipated duration of therapy. And that was an example of an intervention that was facilitated by meeting with our pharmacists, who could also provide wonderful information about the drugs, appropriate dosing, and would help facilitate identification of appropriate duration for some more complex infections as well. So that's an example of a pharmacist-based or facilitated intervention that works with hospitalists.
Great, thank you. And as I mentioned, if there are any further questions, please feel free to raise your hand from the icon on your toolbox or type it in. But at this moment, we do not have any further questions. But if any do pop up, I'll make sure to unmute or refer to them. But in the meantime, as I mentioned before, please do follow at SHM Live for more information on our Twitter contest. We will also be participating in a live chat with the CDC next week during their Get Smart Week. But if there are no further questions, I would like to thank everyone for joining us on today's Kickoff webinar. Thank you, Dr. Flanders and Dr. Buawan, for your presentations today. Actually, we got another question. Sorry. So what were some of the QI metrics used to measure appropriate antibiotic use?
I can tell you some of, at a local quality improvement level, we tended to emphasize what we called the rapid tests of change. So we would implement some of these interventions and then look to see what sort of immediate effect they have, and then would look also over longer periods of time. So I think one of the standard things that health systems do is track, days of therapy per 1,000 patient days, which is a decent metric for antimicrobial use. There are a lot of other metrics around defined daily doses that I'm not going to spend the time to go into. Those are often useful at a high level health system, hospital-wide, or ideally if you can do it unit-based or service-based level, which is not always feasible. So I'd say those may be the gold standard. We often used chart-level review for a lot of our patients. We would look and, for example, with the 72-hour timeout, we would ask that the pharmacist jot down what the interventions were related to antibiotics, and we were able to identify in that particular way the percentage of patients that had a stop. So antibiotics stopped at 72 hours. We quantified dose adjustments, and we quantified the change in duration of therapy based on what the hospitalist originally anticipated and what was ultimately decided on. So it was actually quite simple, which we felt was important to facilitating, this type of improvement work. I believe the CDC has a lot of other resources on their website about data tracking and standards for tracking antimicrobial use at the hospital and health system level that I think are very useful for institutions engaged in this type of work. And that their website's another great resource for some of this information.
Great. Thank you very much, Dr. Flanders. And at this time, there are no further questions. And again, I would like to thank everyone for joining us on today's Kickoff webinar. Thank you, Dr. Flanders, and thank you, Dr. Bualwan, for your presentations as well. And as mentioned, the webinar will be available on the www.fighttheresistance.org website. So please feel free to go to the website to download the posters that are available and to share the webinar and webcast with your colleagues and associates as well. So thank you again, and I appreciate everyone's time today.
Thanks, Mabola.
Thank you.